Fellow at Roswell Park Comprehensive Cancer Center. I would like to introduce our speaker today. Dr. Mohammad Umair Mushtaq is an Associate Professor of Medicine in the Division of Hematological Malignancies and Cellular Therapy at University of Kansas Medical Center. He earned his MBBS from Allama Iqbal Medical College in Lahore, Pakistan, completed his residency in internal medicine at Cook County Health Hospitals in Chicago, and pursued a fellowship in hematology and oncology at University of Wisconsin Hospitals and Clinic. Dr. Mushtaq is a clinical investigator with expertise in hematological malignancies, hematopoietic stem cell transplant, cellular therapy, immunotherapy, and global health. He has an extensive record of scholarly productivity with numerous publications and more than 2,000 citations. He has received multiple awards for his contribution to research and education, and he is dedicated to mentoring medical trainees and fellows. Beyond academia, he is also the founder of Mikael Rayaan Foundation, a nonprofit dedicated to advancing global health and humanitarian efforts. Please join me in welcoming Dr. Mushtaq. Thank you.
Thank you so much, Nara. Glad to be here again. This is the second time I'm doing this lecture series. So I would be talking about chimeric antigen receptor or CAR T cell therapy. These are emerging new treatments, especially in the context of developing countries. So it's a specialty in itself, as in transplant is a treatment modality. T cell therapies or immune effector cell therapies are also treatment modalities across different blood disorders and being explored in other cancers. So my goal today would be to give an overview of what CAR T cell therapy is. And my hope would be that you are, like at the end of this 1 hour, you are able to fully understand how these T cell therapies work, what is the existing data in some of the diseases like B cell malignancies and myeloma, and where the future is heading. And it's like a big discussion about how this can be implemented in developing countries. So I have left out that, but at the end, I will briefly talk about a few points about that. I have a research funding from Iovance for a melanoma trial unrelated to this. So we will talk about T cell biology very briefly and CAR T cell therapy, revolution in immunotherapy, CAR T cell therapy in B cell malignancies, where we saw a lot of promise and first approvals happened in that space. New avenues or horizons, so CAR T cell therapy in myeloma and solid cancers. Myeloma is now very well established and it's being explored in other diseases. Autoimmune disorders, limitations and toxicity of CAR T cell therapy, how to manage that, and some future directions. So as you may remember from immunology, this is a very simplified explanation. So in normally a T cells, most of the T cells, circulating T cells have alpha beta T cell receptor, 95% of them. There are some with innate immune system that have gamma delta receptors or NK receptors that work slightly differently, but majority of T cells have T cell receptor. So an antigen presenting, so if there's a cancer or an infection, something happens, your antigen presenting cells, dendritic cells, they'll present that epitope, that antigen on MHC, and the T cell receptor will recognize it. And then this would be followed by second signals that are co-stimulatory signals. So one example is CD28 binds to B7, that's its ligand on the antigen presenting cell. And both of these signals are needed for T cell activation. So once that happens, then the T cells get activated and they will act against that infection or cancer. So cytotoxic T cells, immune effector cells, or usually CD8 T cells, they induce apoptosis through multiple mechanisms. So there is fast cell pathway, there is release of cytotoxic granules, perforin, granzyme B. So it's like a long topic and it's out of scope of our talk, but that's how the T cell mediated killing happens. So in cancers, one of the issue is that the immune system is not activated, so there are inhibitory signals. And the other thing is that the cancer hides itself. The immune system is not able to see the cancer. So chimeric antigen receptor is a modified T cell receptor. So this diagram shows signal 1 and signal 2 on the left hand side, and that's the usual mechanism. Normally that's how it will work. There is an alpha beta T cell receptor, and with that there is a co-stimulatory domain. CD2841BB is also a co-stimulatory domain. And then on the right there are these modified signals 1 and 2, and that's a call. So basically a short chain variable fragment is attached to. So after these changes, in a very simplified terms, so the car is activated. So it doesn't need any activation signal. It's like a little monster cell. It's constitutionally active. And second, it doesn't need MHC dependent recognition. It knows how cancer looks like, and that depends on which target you design it against. For example, in B cell malignancies, it is designed against CD19, so it will recognize any cell that has CD19 on its surface, and it doesn't need any activation signal, so it will kill all B cells. Result would be that there are no B cells left. So B cell aplasia and hopefully remission for lymphoma, and then eventually they'll fade away year to year, and then your B cells will recover. And you can kill all B cells and still live. That's compatible with life. It doesn't work in solid cancers because you can't kill epithelium. So you need to have a unique target that's either only expressed by cancer, or if you target that, the on-target toxicity would be manageable. So how does the cell therapy workflow work? So the first step is to collect the T cells from the patient. And the process is very similar to dialysis. So there is this machine, apheresis machine, the blood passes through that, and there are these beads, they filter out the T cells. And this is very similar to how we collect stem cells. There is no mobilization involved. These are just T cell collected. And then these T cells are sent for manufacturing. The manufacturing is usually centralized for commercial products. For clinical trials, they can be done at various institutions, needs a GMP lab. And sorry, I looked at the chat, and I will get to that at the end. So T cell activation transduction is done. So there are these, and then there are these culture media and expanders, and there are several ways to induce transduction in the T cells. That's also out of scope of this talk. It's more primarily aimed towards clinical part of it. But the basic science, the lab part of it, is it can be done by a lentiviral vector, where you have a lentivirus and you do, it has a payload and it will insert it into the genome. That's how you can make a change. Or you can use a CRISPR-Cas9 based approach. There are several methods to do that. There are closed and open systems to do that. And the cost also depends on this process. And vector is costly. In the US, a typical CAR-T like a CAR-T product, that just that bag will cost like $500,000. It may be somewhere around $50,000 to $100,000 in many other developing countries, such as China. If you try to buy the vector off of black market, or like in Barcelona or China, or you will still need to spend $20,000 to buy a vector for one patient. And but if you have an open system where you can do it yourself, or if you have a system where you don't need a lentiviral vector, then you can scale it up for globally, or especially in resource limited settings. So we would hopefully at some point talk about this later, but we will get the bag in about 3 to 6 weeks anywhere. Those cells are modified, then expanded, and they are in like millions to billion. And once we have the bag, then the patient will get a lymphodepletion chemotherapy. The purpose of this chemotherapy is not to kill cancer. This is only, it's considered it as a pre-medication. This is lymphodepleting so that you wouldn't reject these cells. And so the patients get about 3 days of fludarabine and cyclophosphamide. I'll have a slide later looking at that. And that will deplete their immune system or T cells. So then you give them this modified T cell infusion. This can be done either outpatient or inpatient basis. It started as inpatient because we were not familiar with toxicities, but now it's phasing out to outpatient. And then the patient needs to be watched for at least 2 weeks. It started with watching them for a month closely, and 2 months they need to be very careful. But now it's about like at least 2 weeks is where they really need to be watched. Like every day they need to be seen, or they should be in the hospital for those 2 weeks. And then they recover. And we will talk later. I will go through the slides, and then I will briefly overview once the patient gets the cells, what happens after that. But just collecting the cells to having the bag infused back into the patient, that's the workflow. So CAR T cell therapy has been named Advance of the Year in 2018 by ASCO. Has changed the face of how we treat cancer, and in future, many cancers would be treated chemotherapy free and with only immunotherapy approaches. So I will briefly overview few cancers where CAR T cells have been successful: ALL, lymphoma, and multiple myeloma. So ALL is a relatively rare cancer. These statistics are from United States, so may not be relevant, but overall 5-year survival is around 72%. And so this is an older study looking at outcomes of patients who relapsed ALL. And as you can see from these curves, after first relapse, 5-year overall survival 7%, 2-year overall survival 11%, and so less than 20%. Most patients died if they had relapsed ALL after transplantation. So this is after allogenic transplant, and small numbers, but again, the curves show the same, that most patients, once they relapse, there isn't anything available to salvage them or put them back on a curative track. After CAR T cell therapy, so T cell in children, young adults with B cell lymphoblastic leukemia, 75 patients were treated. 61% of them did get an allo transplant afterwards. Overall survival was 76% at 12 months, and that since it was single digits in the slides that I showed you earlier, and CR rates up to 80%. And in the long-term follow-up, it is median overall survival was around 13 months, 18 months for Bruxacel. It's a Zuma-3 adult ALL cohort. About half of them got allo transplants, but very remarkable results compared to what we had before these CAR T cells. So based off these studies, these two constructs, Tisacel and Bruxacel, got FDA approved. So this is a 3-year Ileana trial update. So this looks at duration of response, event-free survival, and overall survival in ALL patients. And at 36 months, half of the patients are alive and in remission. So these, if you compare these curves with the other curves that I showed, where the long-term plateau was around 10%, now we're seeing it around 50%. So that's been a remarkable advance. In terms of non-Hodgkin's lymphoma, relatively more common than acute lymphoblastic leukemia, about 4% of all new cases, around the same, 75% is a 5-year relative survival. These statistics are for United States. And these slides looks at Scholar-1 as the first and largest patient-level meta-analysis in chemorefractory diffuse large B-cell lymphoma. So it integrates data from 2 large phase 3 studies. including Coral, and 2 observational cohorts from Mayo Clinic and MD Anderson. And median overall survival, as you can see, is 6 months. So if you have a chemorefractory large cell lymphoma, you will succumb to it within weeks to months. And the curve, even whatever you do, if you do an autologous stem cell transplant in a chemorefractory disease, maybe 10% or so, you'll get allogeneic transplant in a chemotherapy disease will be about the same. You need to achieve a response even for an allogeneic transplant to work. The pooled CR was only 7%. So very no good options if you relapse, if you had chemorefractory disease in large cell lymphoma. And this is Axicell or Yescarta in large B-cell lymphoma. This is real-world experience slide. So it looks at progression-free survival and overall survival. And as you can see that the progression-free survival plateauing around like 40 to 50% and overall survival plateauing in 50 to 60% range. So that is compared to 10% that we had before. So there are many more patients who are cured of large cell lymphoma because of these treatments. And this is a real world example. So this is one of our patients, 68-year-old large cell lymphoma, GCB subtype, had 7 prior lines of therapies, got R-CHOP, got ICE, got RESAP, R hypercytoxin, gemcitabine, bendamustine, R hyper-CVAD. So several different regimens, and then very poor performance status because of the disease, ejection fraction of 45%, has PIs, has GI bleed, obstructive jaundice, has a biliary catheter in place. So there would be essentially no good viable option in this situation. And this patient got a standard of care Axicell, and this is a PET scan 1 month later, and the patient is alive and doing well. So this is also looking at before and after for the CNS disease. So patient remains in CR over 5 years after infusion. So again, the top part would show PET scans and the bottom part would show MRIs, and everything cleared. So these are 3 multi-center landmark trials for CD19 CAR T cell therapy in aggressive non-Hodgkin's lymphoma. So Zuma-1, Juliet, Transcend, different industries sponsored that. CAR T design, CD19, all 3 of them are targeting CD19. CD28 in Zuma-1 and 41BB in the other 2 constructs. The difference is that CD28 may have better expansion but may not persist longer. 41BB may persist longer. Again, out of scope to discuss all these nuances, but there are subtle differences in there. CAR T dose it was about 1 to 2 million, up to 1 billion. It doesn't pan out that the CAR T actual dose correlates, like there is a minimum dose, like a stem cell dose, but then these cells gonna expand when they are infused. So the actual infusion dose doesn't matter like that. It's not like more you give, the better you get a response. There is a minimum dose that has to be followed, and FDA label will indicate that. Conditioning chemotherapy is cyclophosphamide and fludarabine. Juliet study also allowed bendamustine. Lymphoma types for transformed large cell lymphomas, de novo diffuse large B-cell lymphomas, and mediastinal B-cell lymphoma. And as you see that all of them are relapse refractory, and about 1/3 of them has had auto transplants. And median time from apheresis to CAR T is different among constructs. Fastest is what you would want to get in an aggressive large cell lymphoma that's chemorefractory, and excellent CR rates up to 70 to 80%. And all 3 got FDA approved. So again, these 2 are looking into the second line setting. So these patients you can consider second-line CAR T cell therapy versus autologous transplant. And now we have good data, and 2 products are FDA approved, and that is now the current standard of care to do CAR T cell therapy in second-line setting if there is chemorefractory disease. If they go to complete remission with a salvage rice regimen in second-line setting, then they can get an autologous transplant. So this is Zuma-7, so standard of care versus Axi-cell, improved overall survival by 10 to 15% points. So this is current recommendations of management of large cell lymphoma. So aggressive B-cell lymphoma, you get R-CHOP or similar, and about 60% of these patients would be cured. About 10% is like primary chemorefractory group at diagnosis. 80-90% will have a response to R-CHOP. About out of those, 25-30% will have a relapse later on. But 60% would not need anything other than R-CHOP. Now we have polatuzumab-based first-line treatments. The slides are a little outdated. If they do get relapse or they're chemorefractory, then they get a second-line chemotherapy. That here at KU we do RICE, it's rituximab with ICE. And if they achieve complete remission, then they get a beam autologous stem cell transplant. And cure fraction would be roughly around 30 to 40% with that approach. If they have relapse progression, they'll get CAR T. If they don't go into remission in the second line setting with chemotherapy, then they will get the CAR T instead of transplant. So there are several trials looking at that CD19 CAR T in high risk B-cell lymphomas upfront. Randomized trials, I don't think will have that CAR T versus transplant. There would be trials about looking at better versions of these CAR T. So, for example, this is just a CD19 CAR T. This is a first generation of these cells. So the next generation would be dual targeted CARs like CD19, CD20, or triple target CARs, CD19, 20, 22. Would you do that in post-CAR relapse, or would you do that upfront? I think there is going to be a trial looking at CD19 versus 1920 trial. I'm not a lymphoma expert by any means, but but there is a lot going on. Field may move to chemo-free approaches in some diseases. Mantle cell lymphoma, overall survival, if the disease is aggressive, there is early progression. As you can see from the curves, it's dismal. And Bruxa-cell CAR T in mantle cell lymphoma, and as you can see from the progression-free survival curve, that hangs around 60%, and overall survival curve around 70%, compared to what we had before. Very similar story as in with ALL and large cell lymphoma. And this is FDA approved based off these ZUMA-2 data. And this is a representative PET scan for a patient. So this is a 50-year-old man, 3 prior treatments, presented with multi-compartmental MCL, circulating disease also. So he achieved the CAR T and PR at 1 month. You can see the baseline scan that it is full of disease, and at 1 month, and at month 3 he cleared the remaining disease, and he remains in remission at 18 months. So this is a 3-year follow-up in ZUMA-5 that looked at Axi-cell in relapse refractory indolent non-Hodgkin lymphomas, such as follicular lymphoma, and excellent curves with 80% response rates going up to 6-year mark, or survival rates 6-year mark, and about 40% PFS rates. And based off of this, it's been approved in follicular lymphoma. So, so far we have talked about acute lymphoblastic leukemia. If you had disease coming after allogenic transplant, there were no good salvage options. Most patients died. There were very few that survived that situation. And now, as I showed you the curve, there's 50-60% patients who survive this. In large cell lymphoma, same story. Within weeks to months, you'll die if you have a chemorefractory disease. And early on, when there were these CAR T trials, the consults we will get would be hospice versus a clinical trial. And now that patient that had no other option, now about 70-80% will respond, but half of them are cured with this approach. And this is just the beginning. Like, there are newer generation of CAR Ts coming. There are other immunotherapy approaches coming, such as T cell engagers. So the future is bright in blood cancers for immunotherapies. Multiple myeloma, so about 2% of cancers, the survival 5-year relative is around 62%. These are again statistics from United States. Multiple myeloma, it was always said that it's not a curable disease, but it's looking like that we may be getting closer to a cure in myeloma with CAR T cells and other immunotherapy approaches. So a lot more to come. And then we have several different targets in myeloma that can be explored. It is considered a chronic disease very similar to indolent lymphoma. So it's the goal of the treatment so far has been to keep it under control so that doesn't cause problems. But we are achieving more and more MRD negativity, sustained MRD negativity with CAR T cell therapies. And I think over the next 5 to 10 years, we will treat myeloma very differently. So these are myeloma survival rates post-transplants. People lived about, on an average, 5-6 years. And now it is getting 10 years and longer. We don't even know, because we'll need to follow these patients in order to get their survival rates over time. If you had myeloma is divided into two big buckets. If you have a high-risk disease, the survival could be 2-3 years. If you had a standard risk disease, it was 5-6 years. Now, if you have a high risk disease, there are a lot of clinical trials in that space, but it could be 4 or 5 years. And if you have standard risk disease, you shouldn't die of myeloma. And we'll talk briefly about the CAR T part here. So we have discussed the CAR T, the T cell part here. There are 2 FDA products approved for myeloma, ide-cel and cilta-cel. Cilta-cel or Carvykti is the better product out of 2, and that has been adopted by most centers. And in next generations, there are more things coming. Both of these CAR Ts are directed against BCMA or B cell maturation antigen. There is a new target that we have now, that is GPRC5D. That's a receptor expressed mostly on the plasma cells. And a lot of clinical trials are looking at both, one, improving the CAR Ts, finding new targets of CAR Ts, and second, what is the best time to do CAR T. They were first studied in when patients were out of all options. So after you have been refractory to 4 lines of treatment, patients were given CAR T cell therapy, and we saw good responses. Then we had trials looking at that in second line setting. So in the second line, len refractory myeloma, or if you are triple class exposed, then you get CAR T, and we saw that the toxicity is much lower and efficacy is much higher. So is it better to give CAR T in newly diagnosed myeloma? If not for everyone, for the high risk population? And there is going to be a clinical trial investigating that. Early relapse myeloma, if you relapse within 2 years of a transplant, extramedullary disease, other high risk features, would you do CAR T early? Would you base it off of MRD positivity? And then there is an unmet medical need population. We need to expand CAR Ts to the community. There's a lot of work that needs to be done there. We need to expand it to African Americans and other socially disadvantaged populations. So BCMA as a target. So BCMA is expressed in plasma cells. It supports the survival of the plasma cells and class switching and production of antibodies. And myeloma cells depend on BCMA for their proliferation and survival. and it's a viable target for myeloma. And now we have several therapies targeting BCMA. So this is looking at CARTITUDE-1, that is cilta-cel in relapse refractory myeloma. I'm not going to go into details of the baseline patient characteristics because that's not the purpose of our talk today. It is more to give an overview of this kind of data is what we are seeing with CAR T cell therapy. But in a nutshell, this was a heavily pre-treated patient population, didn't have any good options left, and we saw excellent response rates. And as you can see, PFS in these curves that goes up to about 3 years, 60% patients have been in remission. And this last weekend at IMS meeting, Dr. Usmani shared recent data, and it goes up to about 7 years, and 40% or so patients are still in remission. So that is very encouraging. And this is FDA approved based of that. And then it is studied earlier line, as I said, that after 1 to 3 lines of treatment, including a proteasome inhibitor and an immunomodulatory agent. And the patients were randomized into standard of care. It was daratumumab, pomalidomide, dexamethasone, or pomalidomide, Velcade, dexamethasone versus cilta-cel. And primary outcome was progression-free survival, secondary outcomes, CR, stringent CR, MRD negativity, sustained MRD negativity, and other standard markers. And saw good responses, and it is FDA approved. So in CARTITUDE-4, prior lines of therapy 1 to 3, and all patients needed to be refractory to lenalidomide. Progression-free survival is 60%, 59% at 30 months versus 25% with standard of care. 30-month overall survival, again, improved. And now we have longer follow-up, and the curves remain separated, and we see a plateau. In terms of outcomes, overall response rate, cilta-cel up to 84% overall response rate, and it is most of it is MRD negative CR. So overall MRD negative CR and sustained MRD. Some sustained is defined at 12 months. And so in patients who were evaluable for MRD, it was 82% in cilta-cel versus 25% in standard of care. And same thing goes for sustained MRD. Duration of response not reached. 30 months duration of response was 67% compared to 35%. So almost double the response rates. And in terms of toxicity, there are 2 unique toxicities that happen with CAR T cells. And we will talk later in a little bit detail about those toxicities. But cytokine release syndrome, neurotoxicity, immune effector cell-associated neurotoxicity syndromes, and peripheral nerve issues. CRS, any grade. So this is in second line setting, and we saw that it's much safer in this setting. So CRS grade 3-4 was only 1.1%, neurotoxicity 2.8%, grade 3-4. Early grade CRS 70%, neurotoxicity up to 20%. Nerve, these are unique issues to cilta-cel: peripheral neuropathy, Parkinson-like symptoms, cranial nerve palsies like Bell's palsy, and any grade was about 10% on the cranial nerve, 9% on the cranial nerve palsy, but much better than when it's given in the later lines. Late toxicity are usually related to cytopenias. So, and they are, and I'll talk about that when we get to toxicities. But patients may have low counts for weeks to months, and as we see here, to treatment emergent infections, like infections that happens while on treatment, grade very similar in both arms, and same for the death. Progressive disease higher in standard of care as expected, but side effect wise is comparable. Second, primary malignancies, there have been some signals about T cell lymphoma, leukemia, or MDS, AML. Yeah, it's hard to say MDS AML because a lot of these patients has had prior autologous transplants. They're heavily pretreated. How much of CAR T played a role versus prior treatments is questionable, but it may trigger a process. Like there may be a clonal change and that may evolve into a more frank disease. Is it possible? Maybe, but that's one area that's being explored. It's relatively rare. As we know from autologous transplant data, it may be up to 2 to 5% risk of secondary hematologic malignancies. How much it will be after CAR T cell therapy, we would need to see longer term data and registry reports. These are just the trial reports. So this is a new novel target in multiple myeloma. So GPRC is a G protein coupled receptor class C group 5 member D. So this is mostly expressed on the plasma cells, also expressed on some nervous tissue. And so the early studies of a GPRC5D CAR T cell therapy in patients who have had prior BCMA targeted treatment, like somebody got a CAR T cell therapy with BCMA target cilta-cel, and then they had a relapse. And then they got this treatment, and you see overall response rates in 80 to 90% range, and CR rates in 40 to 50% range. And phase 2 and other trials are ongoing, and we are seeing excellent responses. And there are going to be trials looking at dual targeting BCMA, GPRC5D, looking at maintenance strategies after CAR T. So this is again a curve. It's a very early phase trial looking at this GPRC5D CAR T. It's a BMS product, and the curves look good. Very safe, very similar to usual CAR T side effects. CRS, didn't see much of a neurotoxicity. Unique side effects to this target have been olfactory issues, is taste and smell, and then some neuropathies. So this is current. NCCN is a National Comprehensive Cancer Network in the United States and provides guidelines for how to treat cancers. So if we look at the most recent version of NCCN in multiple myeloma, it lists CAR T cell therapy as a recommendation. And that's what we're doing. Different centers are different in their practices. Ideally everybody should be treated on a clinical trial. That's what we try to do. But if you have first line setting, you got treated, and then you got a longer PFS with that, and then you had a low level disease, biochemical relapse, you could consider non-CAR T cell second line, like caprolactam, pomalidomide, dexamethasone, for example, with KP maintenance. Or you can also do CAR T, or put them on a trial. We at our center usually would do CAR T in second line setting for all patients who are functionally high risk, meaning relapsing within 2 years of their first line treatment. They have high risk cytogenetics, they have extramedullary disease, they are behaving high risk. We will give them CAR T cell therapy, definitely. Other patients, the slow biochemical relapses after several years is case to case basis. Usually we would watch them on maintenance, and then once there is higher disease burden or disease is quantifiable, then we will give them CAR T cell therapy. There is no maintenance as of now after CAR T cells, but IMiD-based maintenance is being explored. BiTE-based maintenance is being explored. So I think we will figure this out over the next 5 to 10 years. A lot happening in this space. So now I'll get to talking in general about what are some of the issues with CAR T cell therapy. I think I tried to briefly give an overview of how CAR T cell therapy have changed the course of disease, how we manage ALL, lymphomas, and myeloma. In terms of limitations, so access is one of the biggest limitations. So production capacity, uh, leukapheresis, you need to have an apheresis unit. So usually it's at a transplant center. Need to produce CAR T cells. So there is this whole GMP facility and all that is needed. There is a long manufacturing time. So even when within US, when you have all those facilities, there is a refractory lymphoma or an ALL that's chemorefractory, limited options. So you need something that can be manufactured quickly within a week or so, or something that's off the shelf. Need for bridging therapy, so need to have effective bridging therapy. So this should be, that's why it should be earlier lines of treatment when you still have effective bridging treatment, because there is good evidence that if you have low level of disease going into CAR T, it improves efficacy and it reduces toxicity. Underrepresented population, including socially marginalized groups within the US, African Americans, Hispanics, patients who don't have access to care, systemic issues. Then globally, across the world, making these treatments available to all, looking at local manufacturing. How can the science be advanced so we don't need a vector, or other ways of making open systems that can make these products at like a cheaper cost. Lack of response and relapse is another problem. Again, that's the biggest problem always with all blood cancers. When we do allogenic transplants or autologous transplants, relapse is the biggest reason for treatment failure usually. So suboptimal construct, T cell exhaustion, T cell senescence, these are all reasons. Receptor loss, antigen escape. Like if you have a CD19 CAR T cell, that B cell can just lose the CD19 to escape from the T cell based killing. And that's where the dual targeting CD19-20 and 19-20-22, that's helpful. Hostile tumor microenvironment, that will be true in multiple myeloma. Tumor microenvironment is hostile, so it's immunosuppressive. So there are issues with T cell trafficking into the tumor. And that's a big problem with all solid cancer, but within the blood cancer, myeloma presents a challenge. AML also, because there is like microenvironment is all over the place, and there is the T cell activation is a problem. That's in AML, we see that. And trafficking of the T cells to that tumor compartment and then getting activated there, although it's a constitutionally active cell, but it needs all the support. It's not just like one immune cell. There is this whole microenvironment that needs to be conducive to immunologic killing. And then acute and late toxicities, and we will get into that. So in terms of toxicity, consider this as like, this is not chemotherapy. So chemotherapy essentially is a DNA poison. So the side effects we get are related to that cell turnover loss. So we get GI toxicity and hair loss and low blood counts, and that are all related to like stopping the mitotic process. CAR T cell therapies are immunotherapy, so they are activated immune cell, and they are going to activate your own native immune system. So consider this like if somebody has a bad flu infection and your own immune system is fighting the virus, and you feel sick as a byproduct. Like there are all these cytokines and proteins that make you feel sick. You have fevers, you fatigue, you don't want to eat anything, your counts could be low, all those things happen. That can be amplified, and that's how CAR T toxicity presents. So cytokine release syndrome, we got familiar with this term in COVID days, but that happens. So that's an activation of JAK-STAT interferon pathways, and it most patients, they just get a fever. Let me see if I have, no, I don't. So most patients just get a fever and they can be watched. There are different guidelines, but it could go into a sepsis-like situation where you have low blood pressure, oxygen needs, and grade 1 is just fever, and grade 2 would be need for oxygen or low blood pressure, and grade 3 would be ventilation or pressure support and so forth. And treatment is tocilizumab, and it can be given every 8 hours, up to 4 doses, and 100% reversible, like, or at least 95%. It may look scary, but it's very reversible. Just need to be watched and treated the right way. Neurotoxicity presents as encephalitis, so very similar to any viral encephalitis like West Nile or JC encephalitis. So uh, there is usually no structural issue with the brain. We still do lumbar puncture to make sure there's not an infection, or the pressure is not so high. We do the MRI scan, we do the EEG. Same way in CRS, we still treat for infection. In a fever, you can't say it's not an infection. You still do the blood cultures, you still do the antibiotics, you still treat it as it is an infection, but you know it's a CRS, so you would give tocilizumab and treat it as such. And in neurotoxicity, you would make sure you're not missing anything else. There's not a new seizure or a stroke or an infection, but usually all that will come back negative, and it will be non-specific lymphocytic pleocytosis, and that's treated with steroids, high dose of steroids, and will need to be escalated very quickly within hours. Patient may be fine in the morning, and in the evening you'll find patient obtunded, totally out of it. And if it's not treated, it may be fatal, can lead to herniation and death. So steroids started usually with dexamethasone. It could be these are high doses of steroids that are needed. So it could be like 10 milligram of decadron every 6 hours. And it in 6 hours, if there is no change, or 12 hours, then you change to 20 milligram every 6 hours. And you give it a day or so. And if there is no change, or if the patient is going downhill, then you go to methylprednisone 1 gram a day. If that's not sufficient, then 1 gram twice a day, and you give it for 72 hours or 3 days. And you will see that in 2 3 days everybody will wake up. They will need ventilatory support, organ support, all that. Not everybody is going to get to a ventilator. They may be pleasantly confused, like they're not making any sense, but they're awake. That's grade 3 essentially. Anakinra and other immune suppressants are added to that, and there are algorithms and institutional workflows for that. On target, off tumor cross reactivity. So there's some cardiotoxicity, or it depends on what target you are targeting. So on target means CD19 if it's expressed in other places, or BCMA, or if you have, there are CAR-Ts in clinical trials for solid cancer, again cadherin, or like some of those epithelial receptors. So if they're expressed on some normal tissues, that would also be attacked by CAR-Ts. And in solid cancers, that's the limitation. We don't have a target that's only on the cancer and not on the normal cell. And it's so that's one biggest challenge. And the second challenge is how to get those T cells into the tumor bed. Tumor escape, we talked about loss of antigen, and resistance. There are several mechanisms. The cell can become smarter around it. And then there are ways to mitigate that resistance, whether in salvage setting or maintenance setting. So this is infection prevention post CAR T cell. And most of these treatments are done at transplant centers, but now many of these patients gonna get this CAR T cell, spend 2 weeks at that center, and then come back. For example, if they are in a developing country, you could, and if they can afford it, you could send them to a Middle Eastern country, or better China, because there are big programs. They do about 1,000 CAR Ts or so around Beijing. Or so if you send them to China, they'll spend 2 weeks there, and then they'll come back to you basically, and then you'll have to care for that. So need to know what happens afterwards. So there are neutropenic, so they get that fludarabine and cyclophosphamide based lymphodepletion. They are neutropenic for maybe 1 to 2 weeks. But if there is a lot of inflammation, that inflammation suppresses the bone marrow function. And then you have low counts for weeks to months. We check bone marrow at day 28, and if it's hypocellular, you can do similar to aplastic things, like you can do L-Tromopac. You could consider stem cell boost if you have cells, autologous cells, for example, in myeloma patients. But usually those counts would recover within 2 to 3 months. Uh, One way to understand this better is to think about it as in aplastic anemia, where there is an autoimmune attack against the bone marrow. Here, it's all that inflammation and cytokine milieu is mediated by CAR T cells. And it's very variable and depends on the disease burden and a lot of different factors. So patients get flu-cy, and with that they will get prophylaxis, acyclovir, and neutropenic prophylaxis with levofloxacin, and PJP prophylaxis with Bactrim or Ceftriaxone DS. And they get the CAR T cell infused, and up to day 14, they have this risk of all viral, bacterial, fungal infection, and they are on all that prophylaxis. Once they recover their neutrophil count, they don't need to be on a fungal prophylaxis or a bacterial prophylaxis unless they need a high dose of steroids. If they needed high dose of steroids, then they would need about a 4-week mold infection prophylaxis. Uh, Once they are through that low count and the first 28-day period, then usually what we do is that we check their CD4 and CD19 count and IgG. But at least the IgG level needs to be checked because they don't have any B cells. So the risk would be what you see with B cell aplasia. So there is respiratory viral infections. And then for up to 6 months or so, they need pneumocystis prophylaxis and shingles prophylaxis. So not going to go through that. That's very institutional. But one unique and important point is that so those low counts after CAR T manage as aplasia. So give them growth factor support, transfusion support, L-Thrombopac, and they'll recover. It will just a matter of time. Check their IgG levels every month, and if they are less than 400, give them IVIG infusion preemptively to prevent cytopulmonary infections. These are two important points, but others is can be very pragmatic. This is just briefly, somebody asked me this question from one of the developing countries about the dosing. And the dosing is very different. It's slightly different about lymphodepleting regimen. So there are three regimens. The regimen 3 bottom is Tisacel, and the regimen 1 is Axicel and Bruxacel. And regimen 2 is other CAR Ts. And as you see, the flu dose is 30 milligram per meter square, and that's 171 total dose, and that's same in all. The issue is difference is cytoxin dose. So it could be 500 milligram per kilo or 300 or 250. And the total dose, as you can see, that is from 1500 to 3000 milligram. And this is not very well studied, but there are going to be trials. I think now we have good data about like the CAR T's work. Then the next steps are going to be how to make them work better and safer. And that's where the studies looking at the optimal lymphodepletion will come up. We have a few minutes left, so I'm going to briefly review that. So allogeneic CAR T cells rationale is that there is a consistent product quality. It's like a drug. It's off the shelf, don't need to collect, and there are no quality issues involved. T cell fitness is a big issue. So these are not unfit T cells. These patients hasn't been treated. They have not had a cancer. So these are collected from healthy donors. All of these are reasons to think on these lines. And the problem is rejection or GVHD. GVHD we haven't seen really, but rejection of these cells. So these are not your own cells, so they are rejected. And there are several different ways to try to improve that, but still persistence is a big issue. So precision gene editing using CRISPR, there was a 2020 Nobel Prize. And CRISPR-Cas9 system, not gonna go into details of that, but you can knock out the DNA and then you can knock in whatever you wanna do. So there is non-homologous and joining and homologous recombination. And so this is one example. This is CTX110. That's a CRISPR CAR T. There are 34 patients with large B-cell lymphoma at the time of this, when I made these slides. And you can see that the overall response rate is 66% with a CR rate of 40%. It's a little less than the autologous CAR. So that was 80% and 60%. So this is an example of a PET scan that completely cleared up in 2 years, a patient ongoing 3 years in remission. And got this CAR T. So there is a real promise there. They just need to get better on that. And I think this option is needed to scale it up to across the world, but also for patients who don't have any effective bridging available and need the product right away, or don't have counts for successful collection. This is again talking a few things about antigen escape, like these are some of the ways the cancer can become smarter. So uh, would be lineage switch, there could be down regulation of the antigen, there could be total loss of the antigen. uh, it requires an in-depth discussion. I'm not going to go into detail of that. This is a trial looking at CD19, 20, and 22 CAR T, and they are seeing good responses. We in-house at University of Kansas have a triple target CAR T with CD19, 20, and 22, and we are seeing good responses in very heavily pre-treated refractory patients. Medical College of Wisconsin and Stanford have previously reported on CD19, 20, a dual targeting CAR, and there is going to be national trials looking at dual targeting CARs. I think that is going to be the next generation of CARs in lymphoma. So in solid cancers, it's a complex diagram, and so is the tumor microenvironment in solid cancers. So a lot of different factors that influence, and for example, we just figured out the immune checkpoint inhibitors, and immune checkpoint inhibitors have made a revolution into how we treat many solid cancers. The same kind of potential exists for other immunotherapies or targeted therapies, and there is a lot of research going on these lines. We are expanding, and this last year we did about over 500 cell therapies. This is a landscape of the industry. As you can see that in all this, there is these allogenic CAR Ts that are like collected from healthy donor. That's what allogenic means. Allogenic T cell receptors, autologous T cell receptors. There are these multi-antigen targeted T cells that are being used in some cancers where there's not a target, or also in cancers when you have progressed after receiving a CAR T cell therapy. There are tumor infiltrating lymphocytes. There are NK cell based treatments. There are gamma delta cell based treatment. There are autologous CAR T cells, and this depicts a lot of products. A lot of products come into the phase 1 to space. Few of them move into phase 3 space, and very few have moved into FDA approval and have been marketed. And this it shows that like the outer rim is the phase 1 to phase 2. So these are the approved product that we use today. So it takes a lot of work to get to that final product, and but a lot of excitement in the field. So wanted to acknowledge Mikael Foundation, Global Transplantation Cell Therapy Consortium. We have established to advance cell therapies in developing countries. We have partnership agreements with Pakistan Blood and Marrow Transplant Group, King Faisal Hospital in Riyadh, Saudi Arabia, King Hussein Cancer Center in Amman, Jordan, and then there are a few hospitals in Morocco and Tunisia, and expanding to others. There is a training program we have started in terms of capacity building. Dr. Mariam Khan is here with us for this month from Armed Forces Institute in Rawalpindi. And this lecture series is one of those efforts. There are research efforts, a lot of things happening. And if you are interested in being part of us, just send me an email, and we'll be happy to get you involved into our monthly meetings. Anyone can join. So very grateful to University of Kansas for supporting me through these years, and I owe all of our work to University of Kansas, MRF Global Transplantation and Cellular Therapy Consortium, and all the family at MRF and University of Kansas. Thank you. think this is all I had.
Thank you, Dr. Mushtaq. That was very amazing presentation, and we learned a lot. From the questions, there was a second question also. What's the role of CML in lymphoid blast crisis with CNS involvement 12 years after diagnosis of CML?
So the question is CML, sorry, what CML lymphoid blast crisis, role of what?
What's the role of CML in lymphoid blast crisis with CNS involvement 12 years after diagnosis of CML?
Meaning role of CAR T cells? I didn't understand the question. So role of what? What?
If you go into the QA sections, this is the second question.
Yeah, for some reason, I'm not able to see that. I'm not sure what they are asking. CAR T cells.
I can put this in the chat.
Yeah, so no, you can tell me what they're asking. So CAR T cell can be used in a lymphoid blast crisis. Yes, you can use them. You can treat them as an ALL. So if they had lymphoid blast crisis, that would need to be treated as ALL. And if they are refractory to chemotherapy, then you can give them CAR T and get them into remission. And then they would need an allo transplant as a consolidation after CAR T. And I would give them TKI maintenance after allogenic transplant and also between CAR T and transplant. If they go into remission with a salvage regimen like blinatumomab, hypersiva, or inotuzumab based regimen, then they don't need a CAR T. But if they don't go, if they have refractory lymphoid blast crisis, then they can get the CAR T. And did I answer that question?
Yes, that question was on, yes.
Thank you.